Hello, everyone. Welcome to your last unit on nasogastric tube insertion, feeding, nutrition, and nasogastric suctioning. Please make sure that you do sign up for your validation after this week and get your validation done ASAP. Don't wait until the last day because the CLC will close. And if you need to redo, it will be closed and you won't be able to redo your validation if you are one of those people. So don't wait for the last day to get it done. Get it done as soon as possible. All right, let's go ahead and get started. So, of course, using ADPI, the first thing you need to do is an assessment. When you're doing an assessment, you want to do a full assessment of a patient's nutritional concerns. What is their usual pattern of eating? Remember, not everybody is a first shift worker or eats at 7 o'clock in the morning. If you came to my room with a breakfast tray at 7 o'clock in the morning and I'm in the hospital, I'm going to be pretty angry at you. You better bring it at around 9. Maybe you have a third shift worker who normally eats dinner at breakfast time. So take that into consideration. If you have a patient who is not eating, maybe there is some other reasons. Maybe it's Lent, maybe it's Ramadan, maybe there are some cultural considerations that need to be looked at. If you have a patient who has a body requirement with an altered nutritional status, so in other words, they are looking malnourished or underweight, we need to take a look at why this is happening. Is it that they don't have access to cook their food? They don't have access to get food? Maybe it is a psychological problem and they don't have an interest in eating. And the other hand, if you have a patient who has an altered nutrition that is more than what their body requires, again, we need to look at why this is happening. Is it a financial consideration? You need to look at, how much income do they have? What costs more, a bag of apples or a bag of chips? Of course, a bag of apples costs more. So with limited financial resources, they're going to eat the chips. They're going to eat the poor ground beef that is, 70% lean rather than eating a turkey that is, 99% lean. So we need to take a look at what is financial considerations for these people. Is it a sedentary lifestyle that's causing this problem? We're seeing a lot of younger people that are becoming obese, and a lot of it is their sedentary lifestyle because of increased technologies. Instead of getting on their bike or walking to their friend's house to play or to talk, they're logging on to Xbox or something like that, and they're playing with each other over Wi-Fi or technology. When we're looking at our interventions and our outcomes, please make sure that you're using the acronym SMART, that your interventions are attainable, that they are realistic, that your outcomes are time-stamped, and that your outcome matches your intervention and it also matches your diagnoses. If you have a patient who's having a swallowing or chewing difficulty, we need to, again, do our assessment. Looking at ADPI, what is the first thing we do? We assess. So why are they having a problem? Is it that they are physically having a problem with utensils or with getting the food to their mouth? Are they having difficulty with chewing or swallowing? Maybe they don't have their dentures in their mouth. Maybe their dentures don't fit right, or maybe they have sores in their mouth. Maybe we need to have occupational therapy come and take a look at that. Maybe we need to have a speech pathologist come and do a swallow eval for them. Difficulty in swallowing or dysphagia is a symptom of something larger that is going on. So maybe this is a problem with their neurological system. So there's nerve damage somewhere or brain damage. This usually happens with somebody who's recently had a stroke. They'll have difficulty in swallowing. This is where we want to get our speech pathologist involved and do a swallow evaluation or a swallow study. When you are feeding somebody who does have a swallowing problem, never, ever, 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 ever leave them alone with the food, even if it's just for a few minutes. You know, you always hear the cardinal rule, you never leave a baby in a bathtub even to answer a phone, because that, second that you are gone, they will drown. Same thing, somebody who has difficulty swallowing, never leave them alone with the food. They will grab a hold of it, they will swallow, they will choke, and you will have a whole world of problems on your hands. You can use resident assistants in nursing homes, volunteers, family members is a great use of resources. CNAs, techs, they are all fabulous people to help feed our patients or clients. When they are swallowing, have them slightly flex their chin down towards their chest. It'll help to open up their esophagus so that they can swallow better. When you are a nurse, I know you will be tempted to give them larger bites of food so we can get the food in them, get them down so you can move on to the next patient. You are really going to be stressed for time. Don't do it. Small bites. Allow them to chew. Put the spoon or the fork down while they are chewing. Ask them, is it done? Is it gone? Maybe have them show you if they're unreliable. And then ask them, what would you like a bite of next? Then go ahead and put that on the spoon or the fork and then give them another bite. I recommend having them sit up in a chair, feeding them in bed. First of all, I would not prefer to eat in bed, but make sure that they are sitting upright in bed. Make sure that they are clean. Have them wash their hands. And then leave them upright for at least 20 minutes. My cardinal rule is at least 30 minutes if they can tolerate it. And again, if they're holding food in their mouth for longer than 10 seconds, this is a big, big problem. They will choke. Make sure that they spit the food out, and then we will try again with another bite. But don't let them hold that in their mouth. Talking about this a little bit further, again, using occupational therapy to come and do an assessment. Maybe they just need adaptive tools. Maybe they need a swallow study. Maybe they need a different type of diet. Maybe they need something like mechanical soft diet, where things are very soft to eat. Nothing is hard, like steak would be hard to chew. A hard carrot, we wouldn't give them something like that. All the food is very soft to chew and easy to swallow. Nothing would be a choking hazard like small peas or pieces of corn. Those would be choking hazards. They could be on a pureed diet where it's all pureed up, looks like baby food almost. We can even thicken liquids so that it's easier for them to swallow. There is no taste to it, so you can even thicken water so that it's nice and thick, almost like a pudding consistency if they need to. So I know it's strange to be giving somebody water by spoon that looks like pudding, but it is just water and it just tastes like water. I do really, really want you to go back, log in on your own to the PowerPoint. I'm not able to do it with the screencast. And please watch this video. It is a fabulous video. Think about this patient and you are the nurse. Where is the family members during this video? Do they have them come back immediately and they tell them everything? What was this patient doing before this horrible stroke happened to them? And how can we get them back to being as normal as possible and yet giving them the ability to be as independent as possible? When we're looking at things like anorexia, this is a symptom of something that's going on. There's many reasons why somebody can be anorexic. It could be as simple as a mineral or a vitamin deficiency. They may have pain when they are eating, and that causes them to become anorexic. They don't want to eat. Some medications cause you to be nauseous or unable to uptake the nutrition that you need. Maybe they have cancer. The tumors themselves are taking all the nutrition from the body so that the tumor can grow. However, if it is a psychological problem that they are anorexic, do know that this is a problem because you do not have one patient, you have two or more patients. Anorexia is a learned behavioral health problem. So if it is true anorexia from a psychological standpoint, find out who they learned it from, because it is a learned behavior. They have a friend or somebody else who needs help. There's many ways that we can stimulate somebody's appetite. First and foremost, when you are feeding somebody, especially in the hospital, make sure that they are clean. They're not sitting in a dirty Depends, that the environment is pleasing, it doesn't smell bad. Move them to a different place if you need to. If they're in pain, give them pain control. Yes, we can use cannabis in pill form to stimulate the appetite. We can also use alcohol as an aperitif to stimulate the appetite while people are in the hospital. Alcohol is not a bad thing. So there's lots of different ways that we can help stimulate that appetite. Having people with them while they're eating is also a way to stimulate the appetite. Being alone while eating, you will eat, you're a patient, you'll eat less while you are alone and eating at home. They say you will actually eat more because you're kind of stress eating or depressed eating, but that's a psychological thing. When in the hospital, have people with them, and that will help to stimulate their appetite also. When you have people who are on problems with eating, keep evaluating them. Maybe they don't need those adaptive devices anymore. Maybe now they do need a different adaptive device. Maybe they were on a mechanical soft diet before and now they've gotten better and they can eat normally. Maybe they've gotten worse and they were on a mechanical soft and now they need to go to a puree diet. So continue to evaluate and assess your patients for their diets and their nutritional needs. Enteral feeding is any time that we feed somebody without them actually chewing and swallowing. So we're going to directly access the GI system. We can do this with a nasal gastric tube that goes through the nose into the stomach, with an oral gastric tube that goes from the mouth to the stomach. We can also make a small slit in the abdomen and put a feeding tube directly into the small intestine, into their jejunum or into their stomach, depending on where they are. Never ever would we give a large bolus of a feeding via a J tube because you can cause diarrhea or dumping syndrome. And also, if an NG tube comes out, it can be placed at the bedside, absolutely. However, they do need to have an x-ray to check the placement for that NG tube before you continue with your feeding of that. This will conclude the first portion of this presentation. Please load presentation number 2. Thank you.